again to thank APTA Aquatic Section for sponsoring this track and being here at WAHC this year. It's my privilege to introduce a fellow mountaineer, and we did beat Texas last weekend. Oh. Dr. Paul Chantler, who's an assistant professor in the School of Medicine, Division of Exercise Physiology, West Virginia University. He received his PhD in Cardiovascular Exercise Physiology from Liverpool, John Moores University, Liverpool, United Kingdom. His training, under the guidance of some other doctors I'm not going to attempt to pronounce, continued at the National Institute of Aging, the National Institutes of Health. He joined West Virginia University in 2009. His research interests focus on examining how the age-disease interaction impacts the structure and function of the heart and arterial system, and which therapeutic interventions are best suited to reverse or delay the progression of cardiovascular complications. Dr. Chantler's lab is currently funded by the American Heart Association Clinical Research Program grant to examine the effect of resistance versus aerobic exercise training on arterial and cardiac function in individuals with the metabolic syndrome. And as announced this morning, he just got another new grant from here. Please welcome Dr. Paul Chantler.
Thank you. Just so I can keep track of time. There we go. I don't want to go over lunch. Okay, thank you very much for the lovely welcome, and thank you, Dr. Becker, for the invitation to present to you guys today. So what I wanted to do is spend the next 35, 40 minutes just discussing the work that I'm currently doing at WVU, elaborating some of the effects of cardiovascular disease on particularly the blood vessels and the heart and how they interact with each other to further accentuate the disease risk profile. In addition, I'll go over some various therapeutic techniques to try and reverse these abnormalities. Yes, most of it right now is land-based exercise, as Dr. Tatanka has already highlighted. I will touch upon evidence that suggests that water-based exercise would also be beneficial for the blood vessels and the heart, and talk a little bit about what is missing and what is required to move this type of research forward with respect to the blood vessels and heart and cardiovascular disease risk. Okay, so unfortunately about 83 million individuals in America are affected by to some extent, cardiovascular disease, whether that be hypertension, diabetes, obesity, myocardial infarction, etc. And you can see that most of this risk is around this Appalachia region. So as Dr. Tatanka alluded to, that over the last 30 years, the amount of deaths associated with cardiovascular disease has actually dropped by approximately 23%. And that's the primary reason for that is better understanding of the disease process. We're able to better treat patients with hypertension, type 2 diabetes. Yes, they still have that increased cardiovascular disease risk, but they don't seem to be dying as frequently. However, having said that, one out of 3 deaths is attributed to cardiovascular disease and is the leading cause of death in the United States. So we have a lot of work to do. And despite this reduction in cardiovascular death rate, there's a massive health disparity associated with this Appalachia region, in which they have a 2-fold greater disease death rate profile than the general population, as you can see here. Partly due to socioeconomic reasons and basically the lifestyle factors. Unfortunately, we have a staggering increase in individuals presenting with hypertension, type 2 diabetes. In addition, we have an obesity epidemic that unfortunately has translated into the Statue of Liberty gaining some weight. It's also international. The Queen's corgis have got overweight as well. And because of this, there's a dire need to get them back to normal. It's come from the English government and the monarchy. But with all joking aside, the latest polls from the Centre for Disease Control I've indicated that 36% of the American population are obese. The next slide is going to transition from 1985 to the modern time. And I just want you to take a time to look and see how the staggering percentage of people presenting with obesity and how it's really set into an epidemic. In fact, the 36% of the population presenting with obesity is kind of misguided, because there are subgroups, specifically African-American women, 80% of which are overweight and 50% are obese. In addition, as I alluded to before, the socioeconomical factors, for example, the lower your social economic status, unfortunately, the higher your obesity. And as we're in 2005 now, you can see, unfortunately, West Virginia is one of the key states, even though there was probably an error back at the last slide, to indicate that they have more than 30% of the population in West Virginia are obese. And unfortunately, that has a substantial impact on cardiovascular outcome as well as its function. In addition, most diseases do not present in isolation. There are a number of individuals who are overweight, who are also hypertensive, and also diabetic. When you have a clustering of these metabolic risk factors within a given individual, the modern-day term for that is metabolic syndrome. So that's a multiple cardiovascular risk factors clustering within a given individual that increases the cardiovascular disease risk rate threefold greater than individuals presenting without metabolic syndrome. And unfortunately, as I said, that's occurring more frequently, especially because of the epidemic in obesity. Indeed, approximately 24% of the population have metabolic syndrome. Unfortunately, also, the occurrence of metabolic syndrome increases as we get older. Indeed, people over 60 years of age, almost 45% of those individuals will have metabolic syndrome. So there is a drastic need to try and attack these important risk factors, to prevent an event occurring, but also to improve quality of life. Unfortunately, the metabolic syndrome, there's bidirectional interactions between all of its independent risk factors. Essentially, it's a melting pot which has substantial influences on the blood vessels and the heart. There tends to be a systemic, low-grade, but chronic inflammation. Now, inflammation is typically a physiological response to a biological or physical stimuli, harmful stimuli. And the physiological response is trying to reverse back the changes to ensure homeostasis. However, what was once thought as innate adipose tissue is actually very metabolically active tissue. Indeed, adipose tissue, not just in the abdomen, but also surrounding the heart, known as pericardial fat, or surrounded the blood vessels, known as perivascular adipose tissue. They release pro-inflammatory cytokines, directly impacting the blood vessels and the heart by changing its function and its morphology. So these excess adipose tissue releases these inflammatory markers in the bloodstream, and also to have direct impact on the structure and function of the heart and blood vessels, and it can have a deleterious effect and increase your cardiovascular disease risk. Now, we also can look at hypertension. Hypertension, when not treated, can cause increases in cyclic stress, which increases your pressure exposed on the walls of the blood vessels and also the walls of the heart. The heart and blood vessels don't like that increase in stress, so they want to adapt. They increase the thickness of the walls above the heart and blood vessels to reduce the excess stress imposed upon it. Unfortunately, that initial physiological adaptation, if this initial stimulus is not prevented, can result in pathological changes in which the increase in thickness becomes too much, and actually the heart then starts to dilate and get thinner, and that can lead into heart failure. This increase in stress imposed upon the heart increases the myocardial oxygen demands as well, so the heart's having to work harder, and we always want to have a nice carefree life, so we're trying to reduce all that. But again, the outcome of hypertension will be physiological adaptations to the blood vessels and the heart that result, if not treated, in a further increase in pathological changes leading to cardiovascular disease risk. So to summarize so far, we have these important risk factors, age being one of them also, which I have not alluded to. These risk factors cause an increase in oxidative stress and inflammation that can act on the blood vessels to cause changes in not only its structure, but its function. And yes, the heart and blood vessels are also linked together, so when you have alterations on the blood vessels, it's going to have a direct impact on how well the heart's going to perform. For example, if the blood vessels get thicker and stiffer, the heart's going to have to increase its force of contraction to overcome the pressures exerted upon it by the changes in blood vessel structure and function. So here we have bidirectional interactions going on, one affecting the other and vice versa, that can result in a clinical event. So my research is interested in examining how people who have a clustering of these risk factors, known as the metabolic syndrome, cause alterations to both the heart and the blood vessels that ultimately increase your risk of having a cardiovascular event. And the recent grant I was awarded by the National Swimming Pool Foundation will examine these interactions and see whether we can try and break this clinical event from occurring by intervening at this point here. So just to go into more detail about what we see, unfortunately, as we get older, there's more occurrence of cardiovascular disease. There's an age-by-disease interaction that tends to occur. And this is one of my mentors' graphs, whose figures who's been around for about 20 years, this figure. But it speaks specifically about how our insight into the age-disease interaction has gained vast knowledge over the last 20 years. And this knowledge has contributed to our ability to treat or to intervene at an earlier stage to try and dampen the age-associated disease interactions. So let me walk you through this slide. So with normal aging, we have normal physiological changes that occur to both the blood vessels, where we see an increase in stiffening and thickening of the blood vessel. There's a gradual increase in systolic blood pressure prior to, not talking about levels seen with hypertension, but there is a gradual increase in blood pressure. Consequently, the size of the heart gets thicker and larger, and our ability to call upon our cardiac function during exercise, the reserve capacity, is also diminished just with natural aging. Now, this line here represents the clinical practical threshold for the diagnosis of cardiovascular disease. So above this line, we present with hypertension, ventricular hypertrophy, coronary ischemia. So factors that as we increase with age, there's an increased risk of diseases that unfortunately end up with brain or heart failure. Now, if we are able to intervene below this line prior to the occurrence of these major risk factors, we will have a good opportunity to perhaps dampen or even ameliorate some of the physiological changes that we see that present individuals with an increased risk of having a stroke or a heart attack. So with the metabolic syndrome, what do we see? We know fairly well how, if you present with hypertension or type 2 diabetes, and to some extent obesity, how the blood vessels and the heart adapt to those stimuli. But as I mentioned, people with the metabolic syndrome, they typically have more than 1-2 risk factors presenting within a given individual. Are those risk factors having cause an exponential change in the structure and function of the heart? And perhaps that's one of the other reasons why they are at a threefold greater risk of having a cardiovascular event than people with one cardiovascular risk factor and also no cardiovascular risk factors. So the last few years, my lab has focused on trying to identify what's physiologically going on in patients presenting with the metabolic syndrome. So let me just give you a quick idea of what metabolic syndrome is, how it's defined. defined as having overweight, so waist circumference, which is sex-specific. So you're either overweight or obese. You're either pre-hypertensive or hypertensive, or you could be on hypertensive medications. You're presenting with hyperglycemia. But for my definition of metabolic syndrome, I do not use people with type 2 diabetes. For me, it's a stepping stone. You have healthy metabolic syndrome, type 2 diabetes with metabolic syndrome, heart failure, or stroke. So I like to try and characterize what's going on in individuals with metabolic syndrome without the extra burden of having type 2 diabetes. So as Dr. Tanga indicated, these are individuals with insulin resistance prior to having type 2 diabetes. So overweight, pre-hypertensive or hypertensive, high glucose but not type 2 diabetic concentrations, high triglycerides, and low HDL. So those are the 5 clinical risk factors for metabolic syndrome, and you need to have 3 out of those 5 to present with metabolic syndrome. Okay, so what do we see? Let me walk you through the meaning of these graphs and what they mean, signify. So the blue bars will represent healthy controls. These are individuals without any cardiovascular risk factor. They are not overweight. They are not hypertensive. They do not have high glucose or poor cholesterol profiles. The red bars represent individuals with metabolic syndrome, as I've just defined them. And this slide here is interested in examining how the arterial function has changed in these individuals. Both are age and sex matched, because age, as I've alluded to, will cause physiological changes to the heart and blood vessels. In addition, men and women, women are very complicated, that's just to say the least, when it comes to looking at blood vessels and heart, all those hormones going off everywhere. So we try and, whatever we do, we match both groups by age and sex, and also the healthy controls here are not physically active. Again, we're trying to compare apples to apples rather than apples to pineapples or whatever you want to do. So we're trying to compare apples to apples. So what we see here is that the patients presented with metabolic syndrome have a higher pulse wave velocity. Now, what is pulse wave velocity? It is a measure of how stiff the blood vessels are. And what was once thought as just essentially a pipe in which blood goes through and gets to the muscles is wrong. Yes, it does have that function of directing blood flow from the heart to the muscles, but it has a more important function, a cushioning function. Every time the heart beats, it will cause a stretch in the aorta. That stretch is important because it stores some of this high energy, and you don't want that high energy to get down to the end organs such as the brain and kidney, because it can cause damage to those lovely tissues, those organs. So the stiffer the aorta, the more pulsatile energy that can dissipate down to the end organs and cause damage. So we don't want that. We want a nice, compliant blood vessel system. So what we're saying here is that the patients with metabolic syndrome have a stiffer system. And indeed, an increase in arterial stiffening has been associated with an increased dementia and cognitive impairment. So they have increased stiffness. Now, another thing that they have is a reduced endothelial function. What do I mean by that? The ability of the blood vessels to open up and close, vasodilate. So what we see here is the patients with metabolic syndrome have a smaller percentage increase in the diameter of the brachial blood vessel. So what we do is we put a blood pressure cuff on their arm, inflate it to high pressures. 5 minutes later, we release that cuff, and a reactive hyperemia response occurs, i.e., there's a sudden rush of blood flow into the region, and normally a very healthy vessel will open up very wide and then return back to normal fairly quickly. But what we see in the metabolic syndrome patients is an impaired increased ability to vasodilate that blood vessel. So stiffer and impaired function so far. And then another thing called intermedial thickness. If you can see this bottom right diagram here, this is an image of the carotid blood vessel in your neck. And here we have the bifurcation before the coronary blood vessel splits off to supply blood flow to the brain. Well, we're interested in seeing how thick this region of the wall is here. Traditionally, IMT, the intermedial thickening, was thought to be plaque. Well, that's partly correct, but majority of it's wrong. Actually, intermedial thickening represents a natural process of aging in which we have a gradual increase in the thickness due to the changes that we see in the remodeling that goes on. Yes, when you have plaque there, the thickness is even accentuated, but typically intermedial thickness is a naturally occurring phenomenon that we see with age. But it's also clinically relevant. So what we see here is that we see the metabolic syndrome patients have more remodeling going on in the intermedial layer. So they have a stiffer system, an impaired ability to vasodilate, and remodeling going on. This is also clinically relevant because a 1 meter per second increase in stiffness increases your risk of having an MI by 15%. A 0.1 millimeter increase in intermedial thickness is an increase in an 18% increase in the risk of having a stroke and a 15% increased risk of having an MI. And you can see that's about 0.1 higher, and that's about 1 meter per second higher. So it is clinically relevant. So we have arterial dysfunction globally right now in patients with metabolic syndrome. Now, what about the heart? So with the heart, we can look at the ability of the heart to relax and also to contract. So let's just focusing on the ability of the heart to relax right now. What we see here is the ability of the blood flowing from the atria into the ventricle. Normally, it's a nice passive response in which the valves open up and blood just gushes straight into the ventricle. At the very end, there's an atrial kick, contraction, to squeeze more blood into the ventricle. As you get older, that response actually reverses, so there's more atrial kick because there's some diastolic abnormalities. But if you remember, I said that again, that these metabolic syndrome patients are age-matched to our healthy controls. So this reversal, what we see here is that there's more atrial kick going on than passive filling. So it's suggesting that there may be some impairment in the ability to supply blood from the atria into the ventricle, so some diastolic abnormalities. But just to look at one variable, maybe misguiding, so we looked at a few more. We looked at the ability of the lateral wall by the mitral valve here to contract and relax. And what we see here is an impaired ability during the relaxation phase. In addition, we looked at the ratio of this E value to the ratio of this E here, and we see that it's also reversed, in which it's high in metabolic syndrome patients. And the ability to, the isovolumetric relaxation time, i.e. the time the heart takes to relax, is also prolonged. So we have 4 variables here suggesting that patients with metabolic syndrome have impaired relaxation of the heart. Now, what about systolic function? Well, we see nothing going on at rest. Both metabolic syndrome patients and controls of the same age and sex have a similar function, or systolic function at rest. As I like to tell my students, I believe that the cardiovascular system is crafty. It likes to hide things from me. You can have one system which is down-regulated, but another system which is up-regulated could compensate for that change. And then unless you stress a system, you don't really see that deformation or that abnormality from occurring. So I was wondering whether that was true for the systolic function. Or at rest, we see no differences. But what would happen if we were to stress that individual and examine the change? So we did that. We did an exercise stress test on a bike, and we measured cardiac volumes and pressures. And all these measures here, end-systolic elastance, preload recruitable stroke work, ejection fraction, cardiac index, are all measures of kind of cardiac performance, whether one be measures of systolic function, pump function, or just the output of the heart. What you see is a general decrease in the ability of the heart to pump in patients with metabolic syndrome compared to healthy controls during exercise. So there are suggestions that there are dysfunction in heart contraction during exercise that were not evident at rest. In addition, we identified that patients with metabolic syndrome had an impaired ability for the heart and blood vessels to work together. What we want to see is when we exercise is a reduction in this coupling ratio. However, patients with a metabolic syndrome have an impaired ability to reduce that coupling ratio. So there's some dysfunction going on with the interaction between the heart and blood vessels. In addition, the ability of the peripheral microcirculation, the arterioles, to vasodilate during exercise because we want to get more blood flow to the exercising muscles. There's an impaired vasodilation going on as well. So we have a lot of differences going on between the two groups during exercise. So at rest, we see arterial dysfunction. We see impaired left ventricular diastolic dysfunction with a normal systolic functional response. We get to exercise, we see impaired pump function and impaired peripheral vasodilation. All these are important because it helps, there's more stress on the cardiovascular system when you walk, when you're exercising. And often people, when we say about exercising, people perceive people running on treadmills flat out, exhausted at the end of it. This is going to impact people at lower levels of exercise as well, who are just walking to the supermarket or walking to get their Big Mac or whatever. There's going to be functional deficits, so there's going to be more stress and strain on the system. The heart's going to have to work harder just for you to go and get that Big Mac, okay? And indeed, as Dr. Tatanka indicated, we look at VO2 max, or VO2 peak as I call it here, as a measure of risk for cardiovascular disease or your aerobic capacity. And you can see that, again, age-sex matched metabolic syndrome patients have a reduced peak VO2. And the cutoff for heart failure is 12. Typically, heart failure patients in the past, they do a stress test, and if it's around 12, then that may be suggestions that the heart's not able to work sufficiently and needs to be transplanted. Okay? So we need to act. How do we act? We need physical activity. 29% of the population are physically inactive. That's a major issue. And I'm sure that's actually higher in those health disparity regions. So can exercise work? Well, yes, it can. There's numerous evidence out there from land-based exercise indicating that physical activity can help. Indeed, regular performed physical activity is associated with enhanced arterial and cardiac function and a reduced risk of cardiovascular disease. But most of the research is being acquired from land-based exercise. So I'm going to start the next part discussing what we know with my research with land-based and other people, and then we'll touch upon how the aquatic environment may also be beneficial. This is a meta-analysis study by Justin, who examined the range of changes in femoral carotid intermedial thickness and also its diameter. So here we have the changes in diameter from spinal cord injuries, in which we see that the diameter of the femoral artery gets smaller. And you can see that as the ability to be active is gradually improved, we can see that the diameter actually gets larger. So the more physically active you are, for example, the elite endurance-trained athletes will have a large diameter of the blood vessel. And that helps because it reduces the stresses of pressures on the walls of the blood vessels and the heart. In addition, if we look at the intermedial thickness of the femoral artery, we see again that there's a thicker vessel for spinal cord injury patients. And again, as your ability to be more active is improved, there's actually less thickening. So one, we have a larger diameter and a thinner vessel in individuals who are endurance trained. Now, this is cross-sectional data. Does that hold up when we look at longitudinal study intervention programs? Yes and no. This is my data, which we're currently under review. These two groups here are both metabolic syndrome patients. We have patients who underwent 8 weeks of exercise training, and then we have our metabolic syndrome patients who maintain their normal lifestyle. That is, they did not participate in any activity. They just maintained their lifestyle for 8 weeks. And at the end of the 8 weeks, we brought them back in, and we measured the stiffness of the blood vessels, and we can see that there was a reduction with about 1 meter per second just over the 8 weeks. And this was not due to changes in blood pressure. Whereas the non-trained individuals, those who maintain their normal lifestyle, show no differences. So that was good. We saw a reduction in stiffness of the vessels. And bear in mind, this was only 8 weeks. However, we didn't see any remodeling going on of the carotid blood vessel. The previous data I showed you was the femoral. This is the carotid. Literature is quite consistent that intermedial thickness of the carotid blood vessel does not really change with physical activity. However, said that, though, most of the research has been done over 8 to 12 weeks, whether longer durations of exercise over years may start to reverse these remodeling, as you would see cross-sectionally with endurance-trained athletes. It's unknown right now. So all I can say after 8 weeks, there was no remodeling, so we didn't see any of the reduction in the thickness of the carotid blood vessel, and we haven't looked at the diameters as of right now. What about cardiac function? End-systolic elastance, well, what we're looking at is the percentage change from rest to peak exercise in the ability of the heart to contract, so every LV contraction here. Again, the left side of here, the red are pre-training, blue post-training in our 8 weeks training group and our non-8-week training group. We can see that the ability of the heart to contract from rest to peak exercise is greater after 8 weeks of exercise training in our metabolic syndrome patients compared to the metabolic syndrome patients who remain physically inactive. We also saw improvements in cardiac index, whereas we didn't see anything in the non-trained group, and a greater ability to peripherally vasodilate the resistant vessels. In addition, this concept known of arterial ventricular coupling, essentially how well the heart and the blood vessels interact with each other, was also improved from rest to peak exercise, so there was more efficient system. And also we had a kind of a clinical outcome as well. We had an improved aerobic capacity in our METS train group compared to, there was no differences identified after 8 weeks in our non-training group. So these data supply evidence that, yes, we see physiological adaptations with metabolic syndrome patients that can slowly start to be reversed to some extent through land-based exercise. But what about aquatic exercise? With the exception of some work from Dr. Tatanka, then there really is very little evidence out there. So let's talk about exercise as previous speakers indicated. We have a number of potential beneficial response effects through aquatic exercise. Less weight bearing, and that may be important for patients with metabolic syndrome because of the excess body composition. There's added water resistance to the movement so we can build up more muscle bulk. The actual exercise feels harder, and as an effect, you actually burn more calories during and after exercise through aquatic exercise training. There's an improved cooling effect, so we don't have the heat exhaustion that we may see on land. There's been suggestions of improved mental health and a reduced stress or risk of injury from aquatic exercise. So all these are great factors, and why don't we look at to see how aquatic exercise can improve the health of the blood vessels and the heart in diseased patients? So, as alluded to, one of the quotes marks from Dr. Tanka's work was, although swimming is widely promoted and recommended as a mode of aerobic exercise by national and international organizations, research focusing on the influences of swimming on vascular disease is lacking. What I would like to talk about is not just swimming. I'm going to support evidence to suggest that swimming is beneficial for the blood vessels, but also I'm interested in looking to see how upright aquatic exercise training is beneficial, not just supine swimming. That's kind of the focus of my research in the future will be for this particular research grant. So what's the current evidence to suggest that water-based exercise may be beneficial? I still got some time? Yeah, okay. Well, first of all, acutely, what happens? You get into a pool, water's up to around the xiphoid process. What do we physiologically see? Because it's the physiological responses in water that occur over a chronic period of time that will lead to adaptations to the heart and blood vessels. Okay, so what do we see compared to land-based exercise? We see an increase in central pressure, partly due to increases in a redistribution of blood volume from the periphery to the central system. This increase in blood volume causes a greater stretch on the heart in end diastole, so there's an increase in preload, end diastolic volume. And using the Frank-Starling mechanism, this greater stretch can cause a greater ejection, a greater stroke volume, and indeed we see a greater increase in stroke volume. Having said that, though, end systolic volume, which is the amount of blood remaining in the heart at end of contraction, also increases. So yes, we have a greater stretch on the heart, and we can therefore get a greater output from stroke volume, but the end systolic volume is still larger. So is there an increase in afterload that's preventing more blood from leaving the heart, or is there impaired contractility during exercise in water? It's unknown. There's also a slight reduction in heart rate, but because of the greater stroke volume, cardiac output tends to increase, and there seems to be a greater peripheral vasodilation. So we have these physiological changes here. which in large may suggest that aquatic exercise may be beneficial. So cross-sectional studies from Neuralin in 2011 has shown that you're looking at the compliance of the carotid blood vessel, comparing sedentary runners and swimmers. We can see that those who have been taking exercise, who are cross-sectionally more active, have a greater compliance, and that's also true of the swimmers, maybe just slightly less. In addition, the stiffness of the carotid blood vessel seems to be less through exercise training, which is the same for swimming, though again, it may be slightly stiffer than what we see in running. So maybe running is a little bit more beneficial than swimming right now based on these data. However, the ability to vasodilate the brachial blood vessel was improved in runners, but not so much in swimmers. And these were age-matched individuals, fairly similar men and women category across the groups as well. That's swimming, yeah. So right now, I haven't found anything about upright aquatic exercise on any of this. I'm just looking at swimming. Another group, Green, has suggested that both land-based exercise and water-based exercise, upright treadmill, there's a slight reduction in percentage of body fat. Now, Hero before indicated that the changes in body fat during exercise is controversial, and it certainly is. So to what extent we can change body fat during water exercise, we're unsure. But let's just say we can. Then I already alluded to that excess adipose tissue increases secretion of pro-inflammatory cytokines, which can cause damage to the heart and blood vessels. So if we're able to start getting rid of some of that excess adipose tissue, perhaps we reduce the amount of inflammatory markers that are released, and therefore maybe we can have an effect on improving blood vessel function through that way. So Hero also looked at 12 weeks of swim training in his hypertensive patients and compared to his attention control. So you saw this before. You saw a reduction in blood pressure about 5 to 6 millimeters of mercury. Now that's clinically relevant. It represents a 42% reduced risk of stroke. So that's important. A 5 to 6 millimeter reduction in blood pressure is clinically relevant. In addition, you can see that the swim training group had an improved compliance. And also, unlike before with the cross-sectional data, you can see an improved ability to vasodilate the brachial blood vessel. So these are all good signs that water-based exercise can be beneficial. What about heart failure? There are a couple of studies that have examined the response into water exercise. So Meyer in 2004 just looked at the acute hemodynamic responses in heart failure patients and found that the response may not be good. In the sense they had a reduced stroke volume. So that is not a good sign. But they also said in that article that the hemodynamic changes did not correlate well with patient symptoms. So the patient symptoms were better than the hemodynamic response. So that was kind of conflicting. And this was only one bout of exercise. Recently, in 2012, ASA looked at 10 patients with heart failure, in addition to having type 2 diabetes, and found that exercising 45 minutes 3 times a week for 8 weeks, you had an improvement in aerobic capacity compared to the control group. They looked at other signs of clinical outcomes such as quality of life. Unfortunately, the small sample size and the large variance in the data because of that prevented any further interpretation of whether quality of life or any other health-related markers were improved. But it did seem to suggest that aerobic capacity was increased in these individuals. So that leaves us to what's now. There was recently a systematic review looking at non-randomized controlled trials, and it alluded to that due to methodological issues, small sample size, and lack of quality of control data, there was an inability to really concisely identify the physiological benefits from swim exercise or aquatic exercise. So what we need is more randomized control trials as much as can be possible done. Also, we need larger sample sizes over a long duration. So we need to track the changing more than 12 weeks, etc. We need adequate control groups. And Dr. Tankard indicated before that there's a question about what is your control group? Is it a control group that received nothing Is it a control group that receives some attention because of the psychological interactions you get with other members? So that's also questionable. So we need adequate control groups. And I think something that is substantially missing is, and even in land-based exercise, our understanding of how or physical activity reverses some of these changes is unknown. There are some suggestions and some hints, but still in the land-based exercise, it's controversial. And in the aquatic exercise, we don't know at all. So one, we need better randomized controlled trials, longer durations, good sample sizes, adequately controlled groups that look at some of the pathways, so how maybe exercising can improve cardiovascular health. So on that note, I'd like to thank you for your attention. Hopefully I don't see anyone asleep right now, so that did okay on that one. Thank you to my funding mechanisms right now, otherwise I would not be able to do research and I'll be kicked back to England. So thank you. And I'll only answer good questions. So the question was, what is a good sample size? Good question, difficult. You need a statistician. Now, what you need to do is, it's called a power analysis, and in order to do a power analysis, you need to have some hints from the literature to suggest what kind of sample size you're looking at. So for the aquatic, what I would do is look at the land-based exercise and say, okay, this person here showed a 1 meter per second reduction in arterial stiffness. They had a sample size of this. We kick in those parameters into a calculation, and it comes back and says, Paul, you need 45 people. It's really based on the variance of the data. Another way to look at it, if there's nothing in the literature, and that is common, is to do a pilot study. So you recruit a few people, maybe 5, 6 people, put them through an intervention or whatever, and see kind of what effect you get from those small samples, and then you put that data in to the power analysis. But what's key for that is how well you control for external factors. External factors being environment, age, sex differences between groups, because you want to get that variance down as tight as possible. Hopefully that answers your question. Thank you. How they measured? Oh, how invasive. So the question was, the techniques I illustrated too on my slides about measuring stiffness, cardiac function, how invasive were they? They were non-invasive. The only thing invasive that we do is take blood samples and look also for genetics and inflammatory markers. We use all non-invasive equipment, very expensive equipment that, most of the audience here are female. If you've had a baby, you've had an ultrasound exam. Well, we use the same type of equipment to look at the structure and function of both the heart and blood vessels. In addition, there's some other equipment that can look at the pulse wave analysis of the vessels. So they're all non-invasive, just really expensive. Any other questions? Great, we get to go for lunch. Thank you.